Hello, my name is Dr. Micaela Wexler. I am a child and adolescent psychiatrist. For 7 years, I ran a clinic for lesbian, gay, bisexual, transgender youth in Kansas City. Sexual dysfunction is broad, fluid, and the definition of sexual dysfunction is imperfect for that reason. There are individuals who experience some sort of disturbance in the sexual response cycle who may not meet the definition of sexual dysfunction. For example, people with spinal injuries who describe themselves as being satisfied with their sexual function despite having physiological conditions which impair the sexual response cycle. Paraphilias are different from sexual dysfunctions in that there is no disturbance in the sexual response cycle, and the person engaging in the paraphilia does not feel pain. For example, exhibitionism, voyeurism, sexual masochism, or pedophilia, which are paraphilias but are not sexual, do not involve disturbances in the sexual response cycle. There is no disturbance in desire, excitement, orgasm of the sexual response cycle in pedophilia, and the pedophile does not appear to be experiencing pain. However, it is recognized as a severe disorder because it involves a participant who cannot give consent, and the recipient experiences severe, long-lasting pain. These paraphilias are in the DSM because they require that the recipient be a non-consenting partner for it to be a disorder. For example, if you're being an exhibitionist at home with a consenting partner, it's not a disorder. It's not a paraphilia. Gender dysphoria was once called gender identity disorder, and it is the most recent change in the DSM. In 2013, with DSM-5, after years of activism, it was replaced with gender dysphoria. Gender identity refers to how a person feels inside. It's not based on how someone looks, not based on body parts. Gender identity is established generally by age 3, although it can be later for kids with cognitive challenges or autism. For neurotypical kids, by age 3, they have learned what is expected of them based on the gender, i.e., when they play house, the boys know they are the husband and the father. This is true even for neurotypical kids who only have one gender parent available in the home. Gender dysphoria occurs when the way one looks is in conflict with how one feels internally. If you look masculine, society has an expectation that you behave in a masculine way. Society does not expect people who look very masculine, who look like men, to dress in feminine attire, be openly emotional, and have a preference for female friendships and female preferred activities. The thing to remember about gender dysphoria is that it partly results from society's gender expectations. There are subcultures in which gender roles are more fluid, and gender dysphoria has a much lower prevalence. For example, Navajo culture accepts more than 2 genders, and therefore it is harder to find people who are experiencing gender dysphoria about their gender in that culture. Gender identity, like sexual function, is also broad and fluid, especially for our youngest generations. Young people accept a broader definition of what it is to be male and female. Many more young people now identify as non-binary than in previous generations. If these people feel acceptance by their families and communities, these individuals are unlikely to experience dysphoria. Kids who have a strong gender identity for the opposite gender, for example, transgender males and females, are more likely to experience gender dysphoria. And just to review, a transgender male is a person who was born with a female body, that is female reproductive organs and characteristics, but they identify as male. And the reverse is true for transgender females. So as medical professionals, healthcare professionals, it is important to validate their feelings and use preferred pronouns and use preferred names. Also, do not lose focus on why they are under your care. For example, a transgender man who is hospitalized for pneumonia. Don't lose sight of the pneumonia. As a child psychiatrist who treated transgender pediatric patients for 7 years, my goal was validation and identifying and treating all comorbid psychiatric issues. I referred patients to the gender endocrine clinic in Kansas City after they had spent 2 years living socially as their preferred gender and had achieved stability in their comorbid disorders. For example, I had a 12-year-old patient I was treating for ADHD who told me they were trans. And they fit the definition of gender dysphoria in that initial presentation of when they told me they were trans. I guided this patient and family in how to live socially in their desired gender. At age 13, this same patient decided they were no longer trans. They were now non-binary and did not desire any anatomical changes. Eventually, they became preoccupied with other life issues and never requested a referral. Another patient, a transgender male, also struggled with anorexia for the entire 2 years that they lived in their preferred gender. At the end of the 2 years, the anorexia was not stable. They were still requiring hospitalization for refeeding. So they did not get referred to the gender endocrinology clinic, even though they had reached the 2-year limit. So the take-home message is, sexuality and gender identity are fluid. We are learning more and more every day. And your patient will benefit from an approach that is accepting and validating.